Hey, it's 8 o'clock, everyone. Good morning. We're on week 7 and it's March 28th. Welcome. I would like to start by introducing our hub. I'm Shannon Switkowski. I'm the clinic coordinator.
I'm Rick Carnacci. I'm the web content producer.
I'm sorry, Jesse Lewis, project manager here at CASE.
I'm Ann Nevar, director for cardio.
Jackson Wright, advisor for cardio. Welcome, George.
Wait, we can't hear him.
Good morning.
Good morning.
Okay.
Hi, I'm Dr. Boland. I'm the co-PI for cardio, and I'm sitting in for Dr. Rao today. I'm sure I won't do nearly as well as him, but we'll struggle along, and really glad to have Dr. Bakris as our visiting professor talking today, and lots of experience with Project Echo to back us up. So that's wonderful. Shannon, did you want to go through the participants? Do we have anyone?
I do not see anyone on the phone that we don't know who it is. So if you would just put your name and your affiliation into the chat box, that would record your attendance for us today. And if there are multiple people in the room, please make sure to enter everyone's names there. You can go ahead.
All right, great. Rick, can you next slide for us? And next slide. So these are the disclosure statements we show every week, except I think has Dr. Bakris has been on there each week, or is that new? Okay, so you guys have seen this each week, and we'll give you just 30 seconds to take a look at that, but nothing new. Next slide. And we'll move just like we typically do. We'll have Dr. Bakris present his didactic today on update on resistant hypertension, and then we'll move into the case after that. So I'll turn that over to you, Dr. Bakris.
Well, good morning, everybody. And unlike what we do here in Chicago, I see I'm talking to the entire state of Ohio with people from Dayton as well as Cleveland. So that's very nice. We don't have that here. Anyway, let me focus on resistant hypertension. There was a scientific statement that was put out very late last year that updated after 10 years where we are with resistant hypertension. Let me have the next slide. And so really there's some new definitions that have been modified because of the overall blood pressure guidelines. And then we really focused on an appropriate way to work up and evaluate the patients, and really focused on lifestyle modification as the base of therapy. The general guidelines, blood pressure guidelines did that, but we were very much in support of that, and really focused as, I would say, give you a preview, SALT is one of the key findings for resistant hypertension. And then we'll talk a little bit about when to refer and who to refer, and how to get appropriate medication. So let me have the next slide. So the updated definition of resistant hypertension, done primarily not because of data that drives this, but to be consistent with the overall blood pressure ACC-AHA guideline, is anyone who is on 3 different antihypertensive medicines, and specifically an appropriate diuretic for kidney function, meaning if your GFR is 30 and you're on hydrochlorothiazide, probably not appropriate, need to be on a loop diuretic, but otherwise a thiazide type diuretic, a calcium blocker, and a maximally tolerated dose of either an ACE inhibitor or an angiotensin receptor blocker. So if you're on all 3 of those and your blood pressure is above 130/80, you would be consistent. It would be consistent with the definition of resistant hypertension. Next slide. And resistant hypertension, you need to understand, is an exclusion. It's a diagnosis of exclusion. It is not something that you make simply by meeting the definition I just said. You really need to exclude all secondary causes of hypertension, primarily primary hyperaldosteronism and sleep apnea. Those are by far the most common causes, but there are other causes such as a FeO and renal artery stenosis, much less common, but still have to consider it. Pseudo-resistance is huge. And what is pseudo-resistance? Patient says they're taking the medicines, but they're not. It's an adherence issue, and definitely needs to be thought of very high in many people. There is masked hypertension. Masked hypertension is a normal reading in the office, but blood pressures, the patients are bringing you BP readings outside the office that are significantly elevated, and definitely those need to be addressed. And then, of course, white coat, which you're all familiar with. And so if you exclude all of that, then, and you meet the criteria that I just mentioned, then we can talk about true treatment-resistant hypertension, which if you, by the way, if you do all this correctly, you're going to find out that true treatment-resistant hypertension is probably only accounting for 2 to 3% of all hypertension. It is nowhere near as common as people think. And that's primarily driven by the fact that nobody has educated them on lifestyle appropriately and really shown them how to do this. And of course, taking of the medicines. Next slide. In the guideline, this is a table taken directly from the guideline. We actually go through and specifically show you specific management considerations based on issues in treatment resistant. And you can see this table is very nice. It's on the slide. If you want, you can print it out and put it somewhere where it's handy as a reference. But we really tried to make this user-friendly, this update. And I'll show you some other things as well. Next slide. Now, this is critical. This is something that I was asked to put together for the JNC7 back in 2002. And at the time, I thought it was pretty hokey because I didn't think anybody would read it or do anything with it. And here it is again in the most updated ACC-AHA guidelines with now expanded data on exercise and changes even in normal tension. So this is a critical table. I strongly advise everybody to print this out and have it available for all staff, PAs, nurses, physicians, et cetera, because it really, I say this because it's important that the patient sees this as to what magnitude of change will occur in blood pressure with these lifestyle changes. And one of the things that I tell patients is a low sodium diet, if followed in the strictest sense, is worth 1 blood pressure medicine. Nobody wants to take pills. If you educate them on proper low sodium diet and they follow it, they see for themselves the power of that, and because you can literally eat through any hypertensive medication. I think people think the meds are magic. They're not. And as I tell the patients, 65% of this treatment is on you, 35% is on me. So yes, the medications are important, but at the same time, if they don't follow low sodium diets, if they're not getting enough sleep, if they're not exercising, you can give all the medicines you want, you will never fully control these patients. So you really, unfortunately, I know none of us are getting paid for it, you need to spend at least 10 to 15 minutes really focusing on how to enable them. And the American Heart Association has some very nice data for the comprehensive centers, for sure, that you can use on dietary modifications, salt, et cetera. And those are really very useful. And so I think it's important. And I don't want to underplay potassium because dietary potassium is also very important. And many people don't appreciate the fact that low potassium can actually raise blood pressure, and correcting it improves it. So very important point. Next slide. Now, sleep is critical, and we don't have time to get into all the details, but here's the deal. Short story. If you're not getting, and this is what I ask the patients, if you're not getting at least 6 to 7 hours of uninterrupted sleep a night, not 6 hours in bed, 5 to 6 to 7 uninterrupted hours, then clearly there's an issue with quality of sleep, and that will lead not only to elevated blood pressure, but increased blood pressure variability. And so everybody immediately thinks of sleep apnea. Well, sleep apnea isn't going to fix everything. In fact, for every hour of CPAP, you only get 1 millimeter of blood pressure reduction. Absolutely important, absolutely needs to be fixed, but this is more insomnia, depression, those kinds of things that you really need to get a handle on, because again, this will dramatically help blood pressure control. And in fact, we're actually putting our data together to write a paper specifically on what is called pseudopheochromocytoma, which basically are people that haven't been sleeping for months. They're presenting as a pheo, all the workup is negative, and you get them to sleep and everything melts away. So very important point that you need to focus on in the history. Next. And this is just from the Nurses' Health Study, make the point that if you're not sleeping well, you're going to die faster. And this is looking at people getting 6 hours of sleep in the Nurses' Health Study. After a 10-year follow-up, a 30% increased risk in coronary heart disease events, and those getting 5 hours of sleep jumps to 82% increase. So very important point about sleep. Next. Now, a couple of things about blood pressure medicines. They are not all created equal. ARBs are definitely different in terms of their blood pressure lowering effects, and so are diuretics. This is a study we did in people referred to us with the definition of resistant hypertension. And all we did nothing more than simply change them from hydrochlorothiazide to chlorthalidone. And you can see very clearly a very nice drop in blood pressure of about 7 millimeters. So, and this was consistent in almost everybody. So this is very important that you understand that the right diuretic they may be on a diuretic, but it may not be the right dose, or it may not even be the right diuretic. If you want to be outcome-based, then we're really talking about chlorthalidone and even indapamide, which has very good data. Many Americans aren't familiar with it because it wasn't marketed well here, but the rest of the world is very familiar with it. And that one is actually more potent. That's why you use 1.25 or 2.5 milligrams compared to chlorthalidone or hydrochlorothiazide. But again, good outcome data there. So very important point. Next slide. The name of the thiazide, chlorthalidone, hydrochlorothiazide, or indapamide. Now, as far as guidelines go, I'm not going to get into this, but there are differences in terms of starting with combination therapy. But everybody's pretty much on the same page, really. The European guidelines want everybody, yes, that is correct, indapamide. Everybody in the European guidelines says if your blood pressure is above 140/90, you start with combination therapy. And there's a specific paper, which I think I included here, that we published when we were at the American Society of Hypertension, on how to use combination therapy and what's evidence-based. So any CCB or any RAS blocker with a diuretic is an appropriate combination, and some have actually been tested in outcome trials. And so that is a very logical way to go. In the US guidelines, they've retained what we said in the JNC7, anybody 20/10 above the goal. But clearly, again, combination therapy is not used anywhere near as much as it should be, and that will improve adherence, single pill combination. So this is a major deal that we say in the resistant hypertension guide. Next slide. And here's the table from the American Society of Hypertension as to what's preferred, because not only is there evidence-based, but you get additive blood pressure reduction, what's acceptable, and what's less effective. And actually, in some cases, it's contraindicated. For example, ACE-ARB combinations are really contraindicated. You may be surprised, the cardiology people may be surprised that ACE beta blocker is there. ACE beta blocker is a beautiful combination for heart failure. It's worthless for hypertension. And in fact, there was a company by the name of GSK that actually paid $1 million for us to prove to them that it's worthless. In an ABPM study that we did, combining lisinopril and carvedilol, was showing an additional 2 millimeter reduction in blood pressure. So I think it's important that you understand beta blockers lower blood pressure by inhibiting renin. So if you're inhibiting the system that ACE inhibitors work on, how do you expect to get an additivity? And so it goes. Next. Now, this is just to make the point that a lot of people are used to doubling the dose of medication, thinking they're going to get more blood pressure reduction. And that's absolutely not true. This is a beautiful study that looked at taking each class of antihypertensives and either doubling the dose in blue or leaving the dose alone and adding another drug from a complementary class. And this looks at incremental systolic blood pressure reduction. And you can see here clearly that you're getting a lot more blood pressure reduction by adding a second drug versus doubling the dose of the same drug. And of course, if you double the dose of the same drug, in most cases, you're going to get more side effects. Next slide. Now, this is data from a study comparing ARBs. Now, this is Valsartan with chlorthalidone, just to show you the differences now. Valsartan, you may not have heard of. It's still branded. It's called a Darby. And olmesartan, I'm sure you've heard of, combined with hydrochlorothiazide. Both of these are in maximal doses, and we use them in people with diabetic kidney disease, just to make the point that these are people with GFRs that are low, and yet these are very good drugs for these people. The indication for diabetic nephropathy is exactly in these people. And so I think it's important to keep in mind that these combinations are good, and both these diuretics work at this level of GFR. Next slide. And yet when you look at the change in blood pressure, you don't really see a huge difference. In fact, I think you'd have to be smoking something to see a difference here. So they are very similar. And so the reason I say this is because they're both very good, and olmesartan hydrochlorothiazide you can get for your patients, whereas valsartan chlorthalidone, which you would argue is maybe a better one because of the better diuretic, is still branded. And even with a deal at certain pharmacies, it's still going to cost the patient about $1 a day. So it's not available really for most people. Whereas olmesartan hydrochlorothiazide, if you have any kind of insurance coverage, you can get a 3-month supply for like $30. So I think it's important to look at this in some combinations. Now, if you look at valsartan versus olmesartan, there's no difference. But I showed you the difference between chlorthalidone and hydrochlorothiazide. And that difference has been seen in multiple other studies. Next slide. Now, here's a head-to-head. Here's a head-to-head comparing valsartan to valsartan, just to show you the difference, maximal doses, and you can see a clear difference in the delta change in systolic blood pressure. And again, why am I telling you this? Because you don't necessarily need to add another drug in certain patients. You can actually switch out within the same class and get better blood pressure control. And we do this all the time. Next slide. And this is, if you want to compare ARB to ACE inhibitor, here's ramipril 10, and here's valsartan, and you could almost superimpose olmesartan there in terms of blood pressure reduction. So ACE inhibitors don't quite give you the magnitude of blood pressure lowering compared to ARBs, at least some ARBs. And this is an example looking at 24-hour ABPM differences in these patients. And if you're seeing a lot of African-American patients, it may be better to use an ARB simply because you further reduce the risk of angioedema and cough. So just a thought. Next slide. Now, what about the fourth drug? You've done everything, you've got everything correct, and now they're still not controlled. What do you do? Well, there is the Pathway 2 study that was published a couple of years ago. Now, this is a double-blind crossover trial done in the UK in general practices, and they randomized everybody initially to placebo, the beta blocker bisoprolol, alpha blocker doxazosin, or spironolactone. And everybody was on the drug for 2 months, and then everybody got randomly crossed over to the other drug till everybody got all the drugs. And this is just the outline of the study. Next slide. And what you can see here is the biggest bang for your buck in terms of blood pressure reduction was with spironolactone, better than the alpha blocker, better than the beta blocker, and obviously all treatments were better than placebo. So spironolactone is what's recommended now in doses of 12.5 to 25 as the fourth drug to be added to the cocktail of a CCB diuretic and RAS blocker. Next slide. Now, everybody worries about hyperkalemia, and I think a lot of people don't have a flavor for this. So I want to give you some general guidance. The kidney handles 90% of the body's potassium. So unless you've got some kind of rare disorder, you really need to look at kidney function to guide you in terms of risk for hyperkalemia. And the people that are at risk are people with GFRs below 45 or have a serum potassium above 4.5 who are already on a diuretic. So if they're already on a diuretic and they've got a GFR of 40 and their K is 4.8, and you want to add an ACE inhibitor, they're going to have a 3 to 5-fold higher risk for developing hyperkalemia. So this is important. Of course, if they have both, you're at higher risk. Now, you can mitigate that by educating them about the potassium content of foods, and there are a lot of things that are available to help you with that. And you can affect serum potassium by as much as 0.5 milliequivalent if the patient is willing to cooperate with the diet. Next slide. Now, this is just the, I'm not going to go through these. They're for you to download and look at, but this is the management of resistant hypertension that we have in the report, and it walks you through everything I just told you in terms of how to start, what to go with, and when to add other drugs. And we even go further than spironolactone and talk about adding additional agents such as beta blockers and combinations of CCBs, etc. Next slide. And then ultimately Minoxidil. I don't know how many of you feel comfortable with Minoxidil, but because it does work. Unfortunately, as Dr. Wright will tell you, we also used to have Reserpine, which worked beautifully. Unfortunately, they don't make it anymore. So we're limited with what we have available to us. Next slide. So when do you defer to a hypertension specialist? Well, first of all, what is a hypertension specialist? So I provided a website for you where this is where you can go and find all the hypertension specialists available in your state or even in your town. And you simply put in the information and it populates with what's there. And if there's nobody closely available to you, it gives you, if you go to your closest city, it tells you where they are. Those of you in Cleveland have no problem because you have a number of people there. But if you're living out in the suburbs of Sandusky or something, it may be more challenging. So anyway, I think that's critically important for you. Any patient that you're unable to control on 3 meds and are afraid of Spiro, or you've given Spiro and you still can't control them, those people should be referred. In addition, anybody that's got a GFR below 30 definitely should be referred to, I would say, both a nephrologist, hypertension specialist. Luckily, at least in Cleveland, you've got some nephrologists who are hypertension specialists, and you can definitely kill 2 birds with 1 stone there. But I think this is important because one of the things that I don't have time to talk to you about is understanding the rise in serum creatinine. And it's perfectly acceptable to have a 30% increase in serum creatinine if blood pressure is controlled. And you don't want it to go above that. And I say this, and again, it's a whole nother lecture, but bottom line is, as long as the patient is well hydrated, this is a hemodynamic adjustment the kidney makes. And actually, in many cases, it gets better over time. So this is important, but that's who you should be referring. Next. So putting it all together, resistant hypertension is defined as a blood pressure greater than 130/80 while taking maximal doses that are tolerated of a thiazide type diuretic, RAS blocker, and CCB. Assuming patient adherence is not an issue, assuming it's not an issue, which is about 50% of the time, spironolactone should be the 4th drug given, as long as the person doesn't have kidney disease. And if they do, if it's less than 45, you can start with 12.5, as long as the potassium is not elevated at baseline. That's one thing I would caution against. Definitely start with single pill combinations if the blood pressure is greater than 20/10. And some you may want to start it just de novo anyway. But remember, all of these things are on background dietary advice and sleep advice. You don't just give the pills out. So you have to educate about low sodium diet. You have to, there's no option. You have to educate about sleep. You have to educate about exercise. And I'll give you a down and dirty tip here that you can use. 2,300 milligrams is the recommendation most people go with, not 1,500, although some people have that as a mantra. You're gaining 3 millimeters of mercury at 1,500 versus 23. Not really worth it for most people, but 23 people can live with. So I tell people, when you wake up every day, your maximum amount of sodium is 2,300 milligrams a day. That's 1 level teaspoon. And so I want you to have some salt, but this is the maximal amount. And if you exceed that, then you're going to pay a penalty. And the penalty is your blood pressure is going to go up. And people get that and they resonate with it and it works well. So it's something I think practical that you should go with. And finally, beta blockers should not be given unless there's for blood pressure control, unless there's a compelling indication. They've got heart failure, they're post-MI, they've got coronary disease. Okay, fine. But then understand that you're giving that as a heart medicine. And while it may affect blood pressure, you need to really focus on the blood pressure itself. It's not really totally approved. These are approved as blood pressure lowering agents and they lower blood pressure, but for a variety of reasons, they're not indicated now, although they do work. And especially if you're combining them with calcium blockers or diuretics, they work quite well. So I'm going to finish with that and see if you have any questions or comments. Thank you.
Are we, great, thanks, Dr. Bakris, that was wonderful. I know there was a question, I think from Crossroads in the chat about getting patients to tolerate chlorthalidone and suggestions regarding side effects. And I think this happens a lot in primary care. We don't use it as much as hydrochlorothiazide. When people are switching to using more of chlorthalidone, there's a level of comfort. What do you say to the patient around side effects and how do you walk them through some of those?
Right. So I tell all the patients, number one, if you do not follow the low sodium diet that I've told you, you're going to pay for it. And I'm going to know about it. I'm going to tell you my secret right now, because you're going to come in and you're going to be complaining about leg cramps. You're going to be complaining that you're peeing all night. That is not my problem. It is your problem. Why is it your problem? Because you're not following a low salt diet. And so guess what? This is working on the kidney. The kidney is just following orders and dumping extra salt. You will find, and everybody thinks, by the way, everybody thinks these are diuretics, so you're going to forever be peeing. Not true. The kidney, after 3 days, reaches homeostasis. And so if you're truly following a low sodium diet, you will not be peeing all night. In fact, you won't be peeing at all. And in fact, you'll get a more restful sleep because your pressure will be lower. And so what I do with these patients is I warn them up front that if they don't follow the diet, they're going to pay for it. And I think that's really an important point in terms of what most people complain about, and that's urination. And remember, diuretics actually lower blood pressure because they actually vasodilate. And as long as your volume replete, they vasodilate. If you become volume depleted, then you vasoconstrict and there's other problems. But I think it's important to understand that these are not just dumping salt. The kidney re-equilibrates. The kidney is a regulatory organ. It will re-equilibrate you to a different salt level, and it will work from that level unless you change it. That's number one. If you have gout, or if you have a history of gout, because that's the other issue here, I always check uric acid on these people, and if it's above 8, I always start them on allopurinol. I start at 100, but you know the new guidelines, you can go up to 800 milligrams of allopurinol. So as long as kidney function is good, even if your GFR is 30, you can take the dose to 300. And if the GFR is 70, 80, you can take the dose up to 600. You don't do it all at once because you can precipitate an attack, but slowly over time, you increase the dose and that will protect them from gout. So I hope that answers the question.
Great. And I think, Bob, you had another question. I don't know if you want to, can we unmute him and he could just ask directly about the ARB versus ACE inhibitor?
Yeah.
On Crossroads. We'll try and unmute. Well, we're getting feedback. All right, we'll just ask it. Are ARBs more effective than ACE inhibitors in African Americans? Because you had talked a little bit about.
You know, there have been many studies, and Dr. Wright can opine on this for a long time. Fundamentally, there are no differences between ACEs and ARBs in African Americans, except for the risk of angioedema, which is 6 times higher with ACE inhibitors in African Americans than Caucasians. I think, again, one of the things you need to tell the patients, if you're going to give them an ACE or an ARB, regardless of race, is if they don't follow a low sodium diet, those drugs, they might as well flush them down the toilet, because a high sodium diet suppresses the renin-angiotensin system, and these drugs work on that system. So if they're taking them and not following a low sodium diet, it's placebo. So they're not going to work. So I think that's an important point.
Great. I had a question myself about the sleep. You know, there's been some studies that have come out around obstructive sleep apnea more recently showing not sort of equivocal effects on cardiovascular mortality, morbidity, as opposed to just blood pressure control, where I know there is an association. And so I didn't know if you could comment a little about insomnia and sleep apnea as it relates to cardiovascular outcomes beyond just blood pressure control.
Right. So I think the easiest way to say this is if you look at the data on sleep apnea, the best meta-analyses and what have you that have been done on sleep apnea, if done correctly, for every hour you use the blower, you're getting 1 to 1.2 millimeter mercury reduction in your blood pressure. And of course, the recommendation is to use it for at least 7 hours. So then you'll get an additional 7 millimeters of mercury, maybe 8 in blood pressure control. That's equal to a starting dose of most antihypertensive medications. And number one. Number two, your heart rate is going to reduce because your sympathetic tone is going to drop, and you're going to be able to mentate and feel better. Now, in terms of reducing cardiovascular mortality, the benefits there are mixed. It's true. It's not a no-brainer that you fix this and everything gets better. The sleep data are interesting because clearly we know, and I showed you some of this data, that if you're not getting enough sleep, your risk goes way up. It's assumed that if you get more sleep, things get better. There's some data that supports that, and I think common sense would support that. But still, what we've found is basically if you fix sleep apnea, you definitely get a benefit, but it's nowhere near as great as fixing insomnia. And when I say benefit, I'm not talking about mortality, I'm talking about blood pressure. And so what the benefit of fixing insomnia is you reduce or almost eliminate blood pressure variability through the day, and you reduce blood pressure itself to the point where we have actually reduced or stopped blood pressure medicines in some people because their pressures have gotten too low. And so I think it's very powerful. Like I say, we're putting this together for a publication, but I think sleep is way underrated and insomnia is way underrated as a major link with hypertension, and most physicians don't even pay attention to it, and I think we need to.
Great. We'll move on to just mentioning that for our statewide cardiovascular conference, just a reminder that we are having that May 17th, and you can register on our website. We have a wonderful keynote on empowering communities to improve cardiovascular health. So hopefully, hope to see some of you there. And I think just the next slide is around, just a reminder, the post-clinic survey will be emailed to you to complete that and let us know about this session to improve future sessions. And I think next week we have
Next week,
Shannon, you
Dr.
wanna-
Larry Lawhorn from Wright State Physicians Geriatrics and Dr. Lance Dworkin from the University of Toledo on